Hello and welcome to Below the Hospital. I'm your host, Garland-Rhea Grisby Sr, Sterile Processing Manager at Sutter Health CPMC. In this podcast, I ask what some might consider hard questions, but what I think are informative questions about the sterile processing profession. And I'd like to welcome to the show someone that I've known for a few years. We have with us today, we have Ted May. Ted, welcome.
Hello, Garland. Great to see you.
Likewise. Now, Ted is president of Andersen Sterilizers, a North Carolina-based manufacturer of gas sterilization products. He's a longtime AMI member, and I personally would say that Ted is an expert when it comes to sterilization standards and regulations. So we're talking to the right person today.
Thank you, Garland. I feel the same way about you, and the many times in the trenches of the endoscope reprocessing group.
Man, the memories. So let's just dive right in, right? Let's talk about low temperature sterilization modality. So what low temperature sterilization modalities are available for instrument processing, and also what gas sterilization technologies are currently used for instrument sterilization? You can take that in two parts.
Yeah, I think in terms of low temperature sterilization and gas, it's pretty close to the same thing. Your choices really are the different hydrogen peroxide systems and ethylene oxide. With hydrogen peroxide, you've got the original gas plasma systems that were introduced back in the early 90s. You've got vaporized hydrogen peroxide, and then you've got the hydrogen peroxide ozone hybrid systems, which have been introduced, not as widely used right now. And in terms of ethylene oxide, a lot of people regard that as obsolete. The old tank-based systems were phased out in 2012, and 3M, which produced their cartridge-based system, 3M sold their healthcare group off to Solventum, and they have discontinued sales of their ethylene oxide sterilizers as of May of last year. For a lot of people, they don't think there is an ethylene oxide option for hospitals right now, and that's simply not true. There's some new systems on the market that are highly gas efficient. They use 90% less gas than anything that has come before them. And the latest of these systems were cleared by FDA in 2020. So you could say in a lot of ways, these are the newest sterilizers on the market. They're compact, tabletop systems, easy to install and operate, don't require their own room. They really bring the proven reliability and compatibility of ethylene oxide in a new 21st century package. It's a big development.
That's interesting. I'm glad you broke that down or explained it in the way that you did, because I know most folks in our industry, at least on this side of the earth, you talk about ethylene oxide, or ETO as we used to call it. I remember we had a couple of those when I first got my start in sterile processing, and folks are like, no, we don't use that. We can't use that. And, the long cycles and aeration phases and things like that. So in talking about ethylene oxide, you mentioned it, so you touched on it. So how is ethylene oxide sterilization relevant to sterile processing departments in health facilities?
That's a great question. 30 years ago, and for a lot of the old timers on this podcast, they remember the old systems, the old ethylene oxide systems. You had a bank of them in every central sterile department. And, they had a lot of problems with them. We are not going to go back to the days when, ethylene oxide is the dominant technology. Right now, central sterile departments have a range of technology, and ethylene oxide is going to be a niche method, but it occupies a very critical niche. Specifically, ethylene oxide is still the most delicate method of sterilization, the most broadly compatible. So for things like electronics, certain implants, very delicate sharps, ethylene oxide is still the best way of sterilizing things. For endoscope sterilization, ethylene oxide has a unique ability to penetrate down long, narrow lumens. We've shown that it will penetrate down a 13-foot, 1.2 millimeter lumen. I mean, it's just crazy in its ability to get into things. It's very gentle. It's the least damaging way to reprocess scopes, so scopes will last a lot longer. And ethylene oxide is the only method that's been proven to stop a CRE outbreak in the facilities that have used it. So it's going to be a niche method. It still is a much longer cycle time, but ethylene oxide fills a niche as a general purpose sterilizer. You know, back in the good old days, the rule of thumb was if you didn't know how to reprocess something, you threw it in the ethylene oxide sterilizer.
Yeah, you know what, man. I remember the good old days. How about that? But it is great to see that ethylene oxide has, not stayed stagnant, right? With the same old way of or methodologies of processing, and now they've moved into, as you say, the 21st century. So now, from the perspective of industry, what criteria is important when weighing which sterilization or high level disinfection method to choose?
Wow, that's a great question. We're asked frequently, what is the best sterilization method? And and everybody that's been in this industry for a while knows, there is no
Hmm.
best method. They all have pros and cons. And I like to talk about this like the game of golf, that, there is no best golf club. You're going to use the golf club that's appropriate to that place on the course. So, autoclaves are still going to be the gold standard for a lot of sterilization challenges. Speed, device turnaround has become a major focus, and so the standard of care has become hydrogen peroxide. They've got the cycle time down, unbelievably. I mean, 20 years ago, who would have thought you'd have a sub 30-minute sterilization cycle? Automated endoscope reprocessors are going to remain the standard of care for endoscope reprocessing. And for other things where you've got particularly delicate instruments where corrosion is an issue, again, I think ethylene oxide has a role. All chemical sterilants except ethylene oxide sterilize through an oxidative process. And oxidation is basically rust. And some are better than others, but they all damage the devices that you're sterilizing. There's a cost that you're paying for the speed of the cycle. And again, the ethylene oxide cycle is still going to be much longer. It's going to be an overnight cycle in most cases. But for a lot of things, it's still the best way to sterilize them. And again, I think the SPD professional is going to look at the task at hand. There are going to be certain particularly critical instruments, particularly critical scopes that may be used on immunocompromised patients where you need the highest level of sterility assurance possible. If you have a patient that has a highly infectious disease and they're going through an endoscopic procedure, ethylene oxide is still the most reliable way of reprocessing, that highly contaminated device. So again, I think that as SPD professionals are evaluating different methods, they've got to accept they've all got pros and cons. And I think the modern SPD is going to have a range of them. One of the things that has come up is smaller hospitals oftentimes have budgetary constraints. They may not be able to afford the full range of technologies that a large acute care facility can. And in that case, I would argue that an ethylene oxide sterilizer is a good general purpose sterilizer. Again, it's not as fast as the hydrogen peroxide systems, but you can put everything into it.
And you know what? And you mentioned something, and I was going to actually ask you that same question, right? Are there new technologies available to health facilities and smaller facilities? Because we do know that there are challenges. Well, there's challenges with large facilities. There's always the question of real estate and how are we gonna fund it. So, and you mentioned those technologies. I mean, you want to touch on it a little more?
Yeah, I'd be happy to. In fact, one of the great things about belonging to Amy, and I'll make a quick pitch here, is that there is a dedicated Amy working group just for new technologies in development. And Amy has a working group that is helping these new technologies create a regulatory path to market. And so, you get to learn about a lot of the stuff that is in the works, so to speak. And among other things, you've got chlorine dioxide, which shows a lot of promise. It penetrates almost as well as ethylene oxide, still has a slightly longer cycle. Chlorine dioxide, by many measures, is even more toxic than ETO. So right now it's limited to an industrial method, but there are a lot of smart people trying to create a hospital version of this. Vaporized peracetic acid shows some promise. That's going to be still mostly a surface sterilant. It's got limited penetration. And again, it's an oxidative process, so you're going to have corrosion issues. Nitrogen dioxide is something that has been in the works for over a decade. Interestingly, it's an ultra low temperature process. It will sterilize down to about 10 degrees centigrade, or in the mid 50s. It's used right now for pre-filled syringes, for drug device combination products. And again, it's mostly an industrial process, but there may be a hospital application in the future. In Europe, the French have put a lot of work into an air gas plasma sterilization process that uses ambient air, and it takes the nitrogen and oxygen in normal air, ionizes in a chamber to create a cold plasma, and sterilizes with effectively no sterilant, no residuals. Very exciting technology, but it's still a number of years from being available in healthcare facilities. So there's a lot of cool stuff in development right now, but again, that, as we like to say at our company, the last 10% of any project is 90% of the work. We'll see, but there is some great stuff in the pipeline.
Wow. So folks, you hear it. There's technologies that's being developed in their beginning stages. There's technologies that's been used and tested for years. There's some that are used and they're trying to figure out how to make it available for us in the healthcare setting. So, yeah, more to come on that. So, if you are in the field in 20 years, you may see some of it come to fruition.
Exactly, exactly.
So, so, so Ted, can you tell me about the scientific process as well as the scientific development process that eventually resulted in Andersen Sterilizers receiving a terminal sterilization claim for duodenoscopes?
Garland, I would love to. In fact, you're one of the best people in the country to discuss this with. Back in 2013, there were a number of CDC alerts
Oh
about
yeah.
infections linked to certain instruments, particularly duodenoscopes. And at that point, here at Andersen, we began working with all the major scope manufacturers on testing scopes and showing that they could be sterilized effectively. We made a submission to FDA in 2014, and that submission rolled over into 2015. And when the 2015 CRE outbreaks occurred, FDA talked to us and said, look, if you want this submission to go forward, you're going to have to pull your duodenoscope claim because something's happening. At that point, a couple dozen patients had been killed. A great many more were injured. And FDA was not clear where the infections were coming from. They were using automated endoscope reprocessors. Everything was being done right, and the organisms were surviving. By interesting coincidence, and you remember this, the first version of ST91, the endoscope reprocessing guidance, was published in 2015. And I remember at Amy that year, we were all looking at each other saying, okay, we got to reopen this guidance document. At that point, we went to FDA and we spent 2 years negotiating with FDA on a testing and validation protocol specifically for duodenoscopes. Pardon me if I geek out for a minute, but when you're validating a sterilization claim on a duodenoscope, the method is to put 1 million spores, 1 million of the most resistant spores, in the least accessible part of the instrument. So in the case of an endoscope, it's right in the middle of the longest, narrowest lumen. And after a couple of years, and after the FDA field investigation into these CRE outbreaks, FDA famously declared that going forward, they were going to regard duodenoscopes as a collection of devices. And as such, instead of inoculating simply one location, we had to direct inoculate 8 different locations on the scope, including using a liquid inoculum on the distal tip and literally painting the spores into the elevator channel and the elevator mechanism. It was unlike any sterilization challenge FDA has laid out before. And we're very proud of the fact that we were the first company to receive a terminal sterilization clearance using this new, much more rigorous requirement. And unhappily for us, we got this clearance in fall of 2020, and we thought this was going to be national news. Unfortunately, in January of 2020, a little something called COVID appeared. And it kind of sucked all of the air out of the infection control space. So what we thought was going to be, just a major, national news item was, largely ignored in all of the attention that demanded by COVID. So I love that story because it required a lot of close work with FDA. We learned a lot in the discussions that took place in the endoscope reprocessing committee after 2015. And you remember more than anybody, there were some very heated debates that were taking place on, is high-level disinfection good enough? Should we require sterilization? I think the truth of the matter is that right now, high-level disinfection is probably good enough for the routine processing of most devices. And as I've said, I think ethylene oxide is going to be a niche technology, but it's a critical niche because, again, if you have immunocompromised patients, if you have a scope that has been in contact with a patient with a highly infectious disease, ethylene oxide is still the best way of reprocessing that device. So, again, a great tool in the box to have in the back of your SPD.
That was an awesome story, and honestly, I'm glad you all stuck it out because some folks can't stand the test of time when it comes to testing and going back and forth with the FDA. Some people just throw their hands up and leave it alone. So shout out to you and your team, for sticking it out for us on the front
Thank you,
line.
Garland.
So let's take this last question here. Now, what do you think the near term, not short term, not long term, what do you think the near term outlook is for low temperature sterilization? Like, are there any new technologies or modalities that you think have promise?
I go back to the challenge of bringing a new technology to market. All of the methods that I mentioned, chlorine dioxide, vaporized peracetic acid, nitrogen dioxide, this breakthrough air gas plasma sterilization method, they're all considered a novel technology by FDA. And FDA's got 3 categories for sterilization: traditional, non-traditional, and novel, which are now category A, B, and C. The novel method is a really tough one because you've got to prove everything. You've got to establish the biological that you're using. You've got to go through all of the biocompatibility testing. It's a very long road. So Again, there's a lot of money being thrown at this. There are a lot of smart people working on these things. I don't see any of these coming to market soon. There's one technology we didn't talk about, which is liquid chemical sterilization. I didn't mention that earlier because it really is not true sterilization. It doesn't have the same sterility assurance level. It doesn't have a BI, it doesn't have a process challenge device. You can't package devices. So I think right now, in terms of the near term, you've got the continuing development of hydrogen peroxide systems. They keep getting better and better. The rapid release BIs for hydrogen peroxide are unbelievable at this point in terms of their turnaround time. And as we discussed, I think that ethylene oxide has also undergone continued development. I mean, there's a reason why ethylene oxide is still used to sterilize most new medical devices today. And I think with these breakthrough systems, they use very little gas. They've been cleared for installation in all 50 states. We've got a lot of systems in California, for instance, which is not easy, I will say.
And not at all. I'm out here.
And as a California resident, you know what I'm talking about. So I think that in the near term, that's what we're going to see is just continued development of the existing technologies. And we're all going to have to just pay attention to what's in development and see how these other systems do in terms of the white papers that are being written, the data that's being shown to FDA. And again, I think in the future, we're going to have some very cool technologies out there.
Nice, nice. Well, Ted, thank you for taking the time out to talk with us. It's always a pleasure speaking with you, and we appreciate everything that you are doing and have done and will continue to do for the field.
Garland, I appreciate that. And I spoke to your other co-chair the other day, and she said that we're going to have to reopen the endoscope guidance in the near future. So
yep.
I look forward to seeing you in the meeting room again.
Likewise. So, folks, as usual, I hope this episode has been useful. We'll be back in 2 weeks with another episode. If you want to support the podcast, you can find us at Below the Hospital on Spotify, Apple Podcast, YouTube, and Amy.org. Until then, see you when I see you.